what some concerns are and where they want to address them. So it's yours, Paula. Thank you for
Thank,
joining us.
thank you so much, Senator. I really
On
appreciate
mute.
that. I'm on mute?
We can't hear you.
Oh,
Are you on mute?
no, it says my audio is on.
I can hear
You
her.
can hear her?
Yeah, we can hear.
Yep,
Oh,
I can
oh,
hear
oh,
her.
I'm sorry.
Sorry.
I can't hear
Good.
you.
I can hear her.
It's me.
Okay,
Sorry. Okay.
that's all right.
Proceed.
Thank you so much, everybody. I appreciate you guys letting me take some time for you today. So, as the senator said, I'm new to Oka. I'm actually from the state of New York, and arrived in Hawaii in September and started my position here with Oka. And just to give you a little bit of background on me, prior to coming to Hawaii, I was the administrator for a 186 apartment assisted living community that was licensed and regulated by the New York State Department of Health in the Syracuse, New York area. And prior to that, a lot of experience with human services organizations over the years. I've been in this field of human services for about 30 years. So really happy to be here with Oka and the state of Hawaii and doing what we can to improve the quality of life for the residents and citizens of Hawaii. So, as the senator said, we've been doing a lot of work recently to look at, some challenges I think that we have within some of our facilities that we license and care homes and things like that. So I just wanted to talk a little bit about that, and kind of what we're seeing and what our next steps and plans are. So, and I think we can all acknowledge that there is a need for long-term care. It's just going to continue to grow. It's certainly not a need that is decreasing. We hold the belief that the quality of life is just as important as quality of care in those facilities, whether it's a care home, whether it is, a CCFFH, whether it's an ALR or an ALF, that is just as important. And we also believe that access to both quality of life and quality of care should not be limited to those who can just afford to pay more. As you guys are aware, we have facilities that have individuals who are privately paying, and then we have, facilities who have, or care homes that have individuals who are, they have Medicaid or Quest, MedQuest, I think it's here in this state. And so they're, having state supplement, to help pay for them, which is obviously not the same rate or as competitive as a private pay. So unfortunately, while the focus on quality of care has become a growing priority, stricter requirements, push for lower staffing ratios, funding for long-term care in general has increased, which causes a dilemma. So while not a mandate specifically for OCA, as a program within the Department of Health, we believe to the extent of our resources that we need to drive improved quality of care and, more importantly, quality of life for our aging Kupuna, regardless of their ability to pay. So just to talk a little bit about the background, which probably most of you are aware of. So I'm sorry if I'm repeating things that you're already familiar with, but Hawaii began regulating care homes back in, I think, 1978. And at that time, the concept of long-term care arches specifically, or those adult residential care homes, were created primarily for the purpose of providing domiciliary care for residents with minimal health monitoring and care needs. And what we are seeing now is a significant change in the acuity level of those individuals who are residing in those care homes. So whether due to lack of nursing facility beds or deinstitutionalization of, say, mental health facilities, like the closing of Waimana Home, or just the natural increase in healthcare needs as our elders have aged, care homes began accepting and caring for residents with higher care needs. Higher levels of acuity often, could qualify them for nursing home level of care, like, just needing more care than what we've typically seen. An example of that, would be years ago that you could not go into a care home if you were not ambulatory, or if you had incontinence issues. That is not the case now. Some of the rules have had to change over time as the acuity level of residents has increased. And unfortunately, staffing and training requirements and public payment for those services have not changed or increased at that same rate. So in terms of initiatives, what OCA is currently doing is reviewing all of the current rules and survey procedures that we have in place to determine how best to improve both the quality of care and quality of life for our Kupuna. And we've asked the senator to introduce a bill that will change the survey requirements to going back to having at least one annual relicensing inspection that would be announced. The purpose of this is to allow a provider sufficient time to review and refresh their understanding of all of the licensing rules and requirements, so that at least once a year, they should be completely knowledgeable of all the rules and have the best opportunity to be compliant in all those areas. We would continue to do unannounced inspections, which would be more focused on areas where improvements are needed, but we really feel that having an announced inspection at the time of relicensing would be beneficial to those care home operators and really allow us to be more consultative in our approach, as opposed to, kind of an I gotcha approach, and more punitive, I guess. So we're currently researching ways to require more training for caregivers who have repeat deficiencies, as well as ways to impose stiffer penalties for non-compliant caregivers. And we'd like to take both kind of a carrot and a stick approach to offering incentives to homes who are always compliant. So we have, a certain number of providers who typically have very few sites. They're meeting the regulations, and we'd like to, if we can, show them, some appreciation for that by perhaps lengthening the time in between surveys. Maybe it would not be a 12-month, maybe it would be 18 months. Abbreviated surveys, things of that nature to, help incentivize that continued good, progress and compliance with regulations, and then imposing monetary fines for homes who have repeat violations, which are already part of the rules, but just I think enforcing that a little bit more and ensuring that that we're following up with those providers in that way. For the CCFFHs, which are the community foster care homes, so we know we're going to get some pushback on this. So we'll need the caucus's support, and we're asking the senator to introduce a bill that would require that all CCFFHs, the operators are CNAs. Currently, only the substitute caregiver is required to be a CNA, and the level of care that these individuals are requiring in those homes really speaks to the need for a higher skill level. And for somebody who is certified, at least as a nurse's aide. So with that being said, and, in terms of our future planning, we're pushing, as a result of the push for the deinstitutionalization of people with mental illness, like the closing that I mentioned before for Waimano Home, and then the state hospital, trying to get individuals who are older out of that facility and discharge Kupuna to care homes who no longer need, hospital level of care, and they need to be placed in a community setting. We've discovered that there are probably over, I think it was 83 or 84 homes where the care home operators are primarily taking these mental health patients. And they are ones who have been established for a very long period of time, which means that the majority of operators may be in their 70s and 80s, and we don't really have a solid, plan for when they are physically, no longer able to take care of individuals in their home. So we need to look at that as part of our future planning and how we can assist those providers transition and have a succession plan in place to provide seamless care for those Kupuna when they are, no longer able to take care of them themselves. I think, acuity levels will continue to see an increase in that. I don't think we'll see acuity levels go down. And that is going to require more staffing. It's going to require higher levels of care in the community. We need to find some creative ways to utilize both the state and federal funds to compensate operators who are providing for these rising acuity levels, as well as to ensure that people can still enjoy some quality of life. The old home care model is completely outdated. What we're seeing is, that it really needs to be overhauled. And as an example of that, in both arches, E-arches, and CCFFHs, operators, can still sleep on the overnight shift. There needs to be someone available to help those residents who maybe need to get up and go to the bathroom. I mean, the risk for falling is much higher when they're, waking up to go to the bathroom, they're getting out of bed, and there's nobody right there to help them because that operator is allowed to sleep or that caregivers are allowed to sleep overnight. Same thing if somebody needs to be turned in bed. And we've talked with our nurse consultants about some of the issues that they're seeing when they're going on these surveys. And some of that is that, the level of care that these individuals need, we don't have perhaps, the caregiver in the home with the right level of training. They're not required to be awake overnight, which certainly presents a risk to those individuals who are residing in that home. So we're looking at that. And we also need to identify what, the most care and cost effective model is that will work in the future. And we need to be seeking dialogue with all of our operators, both family and commercial operators, to brainstorm how we can best manage this going forward. So it's a lot that we're really trying to accomplish. And, I understand certainly that this is not going to be a quick fix. This is over time. We're going to really need to look at how we can make some of these changes. And there's some things we can do quickly, which we're already working on, but some of these require a lot more conversation and a lot more input from everyone. So that's kind of a brief overview of where we are at with OCA. And I'm sure there are probably some questions with all of that. Oh, I think you're on mute.
Are there any questions of Paula? Thank you, Paula. Very good. I like the new direction. And you went to some of the facilities already, so some of these changes you're looking at is based on what you folks have seen, yeah.
Yes, yeah, we've had extensive conversations with all of our nurse consultants who go out and inspect. Specifically, we've focused a lot on the arches right now. And some of the feedback that we've received from them are challenges that, those homes are having with, say, medication administration. They're seeing maybe, medication errors that really shouldn't be occurring. They're seeing challenges with the activities that are perhaps not necessarily planned for residents that are living there. We're finding, that some residents are just not engaging with the caregivers. The caregivers aren't engaging with them. There aren't planned enjoyable activities for them to do sometimes. We're seeing some challenges with some of these homes with cleanliness. And, I think it's very challenging for those care home operators that have the lower paying residents, right? The ones who have that are state funded and are not private pay. It makes it very difficult, I think, for them to do some of the things that we would really like to see them have in place. So looking at that, disparity and how we can somehow try to leverage funds, those are things that Debbie and I have discussed to try to help that situation as well. So that's, a much bigger task. And some of the things we can address immediately, one of those concerns being, the ability for a resident to self-preserve, right? So in a care home, they do need to be able to self-preserve and be able to exit that care home. I mean, the care home does have the ability to have, I think, up to 2 residents who are non-self-preserving, but the remaining residents do need to be able to self-preserve and be able to exit that facility or home safely in the event of an emergency. So one of the things that we've talked about implementing in 2025 is having our nurse consultants, when they're going out to do an inspection, observe a mock fire drill and see exactly how long it takes them to exit, how those individuals are exiting. Is it safe? Do they have a place to go once they're outside? How much assistance do those residents need as they're, can they ambulate on their own? Do they have to have a 1-person or 2-person assist? Does the care home have the staff, the caregivers necessary in number and in skill to be able to assist them with what they need? So those are some of the things that we would put in place, like the mock fire drill initially, to really sort of help us get a good sense of where that particular care home is in that process. So then we can help provide some consultation to them of, okay, this is what, some things that you could put in place to ensure that your residents are able to get out safely. My goal would, I don't want to shut places down. I want them to remain open. We need them. It's to provide them with consultation and with assistance to get where we need them to be.
So what is how do you balance that? Because we don't want to shut them down, yet they're not actually trained, but what if they refuse to be trained, or how does that work? We don't have time, we've got this work to do. How do you balance so that we actually do have quality care, as you're requiring?
Yeah, I think there's a lot of different approaches that we can take to ensure that, operators and their caregivers have the skills that they need, whether that's additional training. And if they're refusing to do training, is it, I think we need to look at that. Is there something that our nurse consultants can do so much when they're there? Just by being on site at those care homes, they can provide so much education and consultation. But I think on top of that, there are going to be some providers that, we may need to institute enforcements against, right? Where we might need to fine them. We might need to, especially if they have repeat citations year after year or time after time. When we go in with the announced visit, that we're proposing to change in the rules, allows us to, have that announced visit as a relicensing visit, their inspection, which is done every year, in the hopes that they will be prepared, saying this, we're coming in this particular month or this particular week, and providing them with a checklist of, this is everything we're going to be looking at, so they can have that prepared, they can be ready. That primary caregiver would be physically present in the home. So they're there to learn and experience that inspection at the time. And then follow up after that and going back with perhaps some unannounced visits, focusing on specific issues that we maybe noticed, right? For example, perhaps, the activity schedule was, pretty weak. So we're going back to look at that again to say, how are those activities being done now? Since we've cited you on it, it was something you needed to correct. You gave us your corrective action plan, and now we're checking it again. So I think it's a multi-level approach. It's not going to be any one thing that is going to completely solve it. It's really looking at it from so many different areas and what we can, quickly put in place, what we need to be planful in terms of, going farther in the future. And then what we need to do to try to even out this disparity between the private pay and non-private pay homes, which is I think in some ways that's a much larger task and will be a little bit more challenging. So there's a lot of different ways, and that probably doesn't answer your question in a really concise way, but
on the heels of that, Paula, one question, and this started the conversation last year, is how many unlicensed facilities or homes are you dealing with? Because if they're unlicensed, you can't go in to inspect. And how are you dealing with that? Because I think that was a bigger problem. I mean,
Yeah.
in terms of being able to give quality care.
Sure. Yeah. I mean, we do get calls from typically the calls about an unlicensed home come in from typically a neighbor, right, who notices that, their neighbor has a lot of, either seniors who are going in and out of the home in wheelchairs. They know that they are not, licensed. So they reach out to us asking, hey, is this particular address? Are they licensed as a care home? And we can let them know whether they are or not. And, then they usually will lodge a complaint. And so we have one of our nurse consultants is primarily dedicated to going out and investigating those complaints. And when we get to that home, sometimes the operator lets us in and we go through and inspect. Sometimes we find out that they actually are licensed. Sometimes we find out that they are not, and they will not let us in. And that I think is, a large problem. And we've been working with the Attorney General, the AG, and local law enforcement to see how we can enforce, you know, filing this as a misdemeanor. They're refusing to let us gain access to inspect, to see if a vulnerable adult is, in harm's way or if they're okay. And so we're working on that to try to come up with a solution for those unlicensed care homes. I think, some of the things that I've heard from some of our nurse consultants, and I think this especially speaks to even licensed care homes, is I think sometimes there's a belief that, there aren't any teeth to, what our regulations are, right? They're not seeing any consequences to that. And I think obviously for an unlicensed care home, if we can't get access and they continue to operate, it's very difficult to do much about it until we can get, the support that we need in order to enforce that misdemeanor charge, right? But for those care homes that are licensed, to hold them accountable to that, this is what the regulations are. You're licensed. And at times, we have had to issue, a notice of violation in the hopes that they will make corrections. My approach would be to try to provide them with as much assistance so we can avoid shutting anybody down. But that's also a two-way street, and we need, care providers to help work with us too. So we can ensure that, we're all on the same page and doing what we need to do.
So where are you with the Attorney General? I thought there was a law that allows you to go into homes that you think are not.
Yeah,
providing
there is, and it does state that it would allow us to charge them with a misdemeanor. I think we're still having conversations about is, are they going to be willing to prosecute that? Do we need a warrant to try to get into the home? Do we want to necessarily go that route? And, gaining access into a private home with a warrant. I mean, there's a whole host of considerations about that we need to be really mindful of and careful as we're kind of proceeding. So all of those discussions, I've been involved with since I've been here. So they've been fairly recent, and I know we have more work to do to see what else we can do to try to move that forward to help stop that from happening with unlicensed care homes in operation.
I guess there's no way for you to tell how many there are out there. Or is there?
No, we can give you figures on how many we've investigated and things like that. And I know the last time I had a conversation with our nurse consultant, I think he had looked into at least, gosh, I want to say he had maybe active at the time, there was maybe 25, but it was, definitely double at least that he had looked at. So it just depends on when we get that call from either a concerned neighbor or a concerned citizen about a particular home. That's when we get involved. Otherwise, it's hard for us unless somebody complains, we don't really necessarily know about it.
So are there any other questions of Paula?
Can I say something? This is
John,
John.
yeah,
Yeah.
John, please.
My camera's not working. Sorry
Sure.
about that.
Hi, John.
Well, hi. So, Paula, you're relatively new. I'm not new. And I strongly think that this is the wrong direction. It took us years to get the legislature to pass unannounced inspections. You can't call it an inspection if you tell people when you're coming. You guys go into restaurants unannounced. Are you now going to tell restaurants when you're coming? All these other industries that you go in and you inspect, are you going to tell everybody when you're coming? I mean, you already know, and you probably know better than anybody, how bad some of these homes are. And so
Mhm.
to say, oh, well, let's let them know when we're coming so they can clean up their act, so we never really find anything wrong. So, gee, these are great homes because we never find anything wrong. You're not going to find anything wrong if you tell them when you're coming. You're the regulatory agency. You shouldn't be afraid about enforcing regulations. So I don't know what's going on behind closed door with the Department of Health, but this is definitely moving backwards. We fought very hard to get unannounced inspections, and I think this is a big mistake. And you know, a patron at a restaurant, oh my God, he might get a roach in his dinner. Okay, that's a lot different from somebody dying of neglect or abuse
Mhm.
in a care home or in a foster home. And the other thing is that, because the audience may not be informed, care homes and foster homes are very different. Care homes, for the most part, they're almost all private pay. They can pick and choose who they want, and they can gouge the price up as high as they can get away with. The foster homes are the ones who are struggling financially. They're only allowed three, only one can be private pay, the other two have to be Medicaid. I'm working on a case right now, a very good care foster home who had to file for bankruptcy because the two Medicaid patients, she has not been paid for over a year. She has one private pay who pays 6,500, and that's keeping the boat afloat. So her Social Security, husband's Social Security, and that one private pay. It's ridiculous that
Mhm.
these health plans get away with not paying. And I see Senator Rhodes, and I had talked to him a long time ago about this, that I was told that there is some kind of a state law that says that if the state does not pay their bill on time, then they're supposed to pay with interest. I don't know if that was ever passed or not, but this woman should not have to be filing for bankruptcy because Ohana and United Health haven't been paying her for over a year, and she's at risk of losing her house. So there's lots of other issues here, but I really strongly oppose telling people when you're coming for an inspection. It is not an inspection. You need to find the bad homes who are putting people at risk, who could be dying. Kids live on the mainland. They're not checking. What do we do in Hawaii? We cremate. Evidence gone. Nobody ever knows. Nobody ever talks about it. It's too painful. Move on. So regulatory agency, do your job, regulate, enforce the rules. Sorry, but I'm a little passionate
Yeah,
about this.
no, I appreciate your feedback, John. And I just to clarify, I just want everyone to hear this. This is not all announced inspections. It would be one announced, and then we would also inspect that same care home at least two more times unannounced in the course of a year. So it is not, moving every inspection to announced. And the change that we've asked, there's some leeway in that language for the inspection to be done. I think it says shall be announced or unannounced. So there's some leeway in there. And really, I think, I certainly support holding care operators accountable when they are not following the regulations. And we have a system in place, to enforce. And I agree, those need to happen. But I also believe that they also need some help in meeting those regulations, and we can provide some consultation to them. I think that's important as well.
So I guess you explained it, but we've got a question again on that, on the, if you can clarify the reason for the scheduled inspections. And that should be in your preamble, because you're still keeping the two unannounced, but the third one would be announced. And if you can explain why you think the announced needs to be added.
Right. I mean, I think what we are hoping with that announced visit is it allows the provider sufficient time so they know that we're coming, to review and make sure that they are meeting those regulations. I think, it's with an announced inspection, that at the time that the state regulatory agency is coming, and you have that time to prepare, and you have that time to, if you don't have everything set the way that it should, you should have some time to get that, your ducks in a row per se. And a refreshing of their understanding of all the regulations that they need to abide by. And then those additional unannounced inspections will happen and can happen at any time.
But Paula, to me, it's sending the message that you only have to be ready when you know we're coming, and the rest of the time, don't worry about it. And in the past, the Department of Health, OCA's has struggled to do the inspections because you haven't had enough workers. So now instead of one real inspection, you're doing 2 inspections, which means do you have the funding to double your staff? Is that what you're going to do?
They're already doing that, John. They're doing a licensing inspection, and they're going back and they're doing 2 other inspections currently right now.
I think one real inspection is all you need to do. Yeah.
So I think
It
along
doesn't
with
have to be
John,
punitive, by the way. I mean, you see something wrong, and based on the severity, if it's something that somebody's at risk of dying, then of course that's very serious. But you don't go crazy just because the house is a little bit messy. I mean, I go to these homes, my staff goes to these homes, tell them when they're coming. They're always clean. These are Filipinos. They're very, very clean. The homes are all beautiful. So that's what they want to do. They want you to see a beautiful home. It's always beautiful. It's the care that we want to focus on. What is the level of care? If that caregiver is working full-time outside the house, and her substitute is her 90-year-old mother who doesn't know CPR and doesn't speak English, we have a problem. We had a case a long time ago where that's exactly what happened. The mother didn't know CPR. A resident choked to death on broccoli. Her daughter, they put the body back in the bed. They called the ambulance. They pretended she died in her sleep, but the emergency room found the broccoli lodged in the throat. So we know exactly how she died. So, those kinds of things, you're never going to find out who is the real caregiver if you're telling them when you're coming, because that's the day they're going to call their boss and say, oh, I got to be home today because OCA is coming to inspect me. So, again, I've lived through this for 26 years. We've already been down that road, and it took us years because the industry had a lot of clout. In fact, before you were in charge, it was Bruce Anderson, and Marilyn Seeley was in charge of the Office on Aging, and we went to meet with him, and he didn't even know that the care homes, foster homes were being told when to get their inspection. And he sent out a letter, I still have a copy, that told the homes we're not going to do that anyway. And they ran to Governor Cayetano, and all of a sudden, everything was back to normal. Ignore the letter has been revoked. That's not going to happen. So it's politics. It's not focusing on what is best for our residents, what is safest, and in particular, because so many of our kids are now living on the mainland. They can't afford housing in Hawaii. They are not checking on their parents like they used to. And so you've got to have real inspections to make sure these people are safe.
I wonder, I've had my hand up for a little bit. I wonder if that scheduled visit could not be maybe more of a corrective action training kind of visit. In Seattle, same kind of approach that you're presenting, Paula. We didn't want to close places. We wanted to help them. We wanted to help them kind of step up to what needed to happen. And so what would happen is if our agency, if we had issues, the state, the county, whoever the inspectors were, would try to come back and try to help teach what was needed to be taught for us. So it was more, if you will, more of a inspirational lesson around what to do, or just how to, kind of thing. Not an inspection. It was more of a follow up to the corrective actions that we have found in a positive kind of way. And then in between visits, there was a lot of information or links to places that we could go and watch, how to's. So it was, if you will, we weren't like a gotcha. It was more like, okay, here, this is what we're kind of seeing. We really want to help, you guys. This is the information, So we're gonna come back on such and such a date. Here's some information we'd like you and your staff to spend time with. When I was at Right at Home, that's a lot what we did with our caregivers that were struggling, and those very homes that we're talking about here. We were for profit, but we actually gave them links to Right at Home trainings that they could actually do, and then we would follow up with them to see how they were doing with that, what they've learned from that, what were the hurdles from there. So that was the schedule. Otherwise, it was an inspection, which was not scheduled. I see a lot of hands up, so I'll stop. Thanks.
Let's see if I can see the hands up.
I see Caroline with her hand up.
Oh, Caroline. Okay.
Yeah.
Caroline. I'm
But
listening.
I want to be respectful of being in the queue. I don't know. I just raised my hand just recently. But Paula, thank you, for what you shared with us. I am in agreement with John that, these should be unannounced. What I do like, though, is that whole idea of really improving the quality of care, ensuring that, they have meaningful activities and that all of that is taking place. So I love that part of it. I do have the grave concerns, though, about announced inspections for all the reasons that John stated. And then thinking in that example with the broccoli is there a liability to the state? And I guess that's another thing that I just wanted to bring to light. But, we can have further conversations on it. I just wanted to kind of just echo the sentiments of our long-term care ombudsman and the staff that see things. And, I think that unannounced is the way to keep it going, and to do it in a way, like Rick said, if there's a way to do it, it's not just gotcha, but how do we make those improvements so that you are in compliance, but just do it unannounced. So thank you.
Thank you, Caroline.
Thank you. Are there any other hands up? Because I can't see any hands or any reactions. So if you do, just speak up.
That's all I see.
Oh,
Okay.
Can you hear me? I don't have a hand up.
okay, speak.
I'm sorry. This is Harrison Peters.
Uh-huh.
Harrison Peters. I'm with the Adult Daycare Association and Day Health Association. Are you going to be talking about some of the issues that we have, or is that what? I want to be respectful, but
Yeah, this is what we're just having the questions and answers for Paula are with
Yes.
the assisted living more the OCA inspections. So not really day health or daycare. I don't think they do that.
okay.
But we could do that another time. But the focus would be on what we can do with the inspections of these 1,500 or so adult assisted living residential facilities. So
Okay.
we certainly have that as a topic for another time.
Okay.
So we could put that on.
I would request that.
Okay. Certainly.
Just to clarify, OCA does have responsibility for adult day health and adult
Corrected.
daycare. Yeah, that's okay. We contract it out for the adult daycare, and then the adult health is those are usually within Medicare facilities. So our Medicare licensing covers the inspections for those, but our state licensing side is responsible for the adult daycare. It's just done with a contractor.
Oh,
Yes.
okay. So Harrison, you can ask your question about adult day care.
Okay, well, no, I don't know if you're aware, but since 2000, and 14 adult day cares have closed in Hawaii. 14. And of those 14, 7 closed in 2023 and 24. So half have, so the momentum is going faster on closures.
Mhm.
And a number of adult day cares they are not keeping and then day health, as far as I know, you had the last one open in over 10 years ago and it closed within less than 2 years ago of an operation. And now there's only 3, maybe 4 adult day health, and they're all in town. So rural Hawaii and neighborhood, neighbor islands have none. So
Okay.
my concern is that it seemed like a whole segment of the senior support network is disintegrating, and then you add to that assisted living, like Ponza Punaluu closed down, and then you have uh, Wahiwa General Long-Term Care closed down, and so we don't. I'm out of from Pearl City to Hawaii Kai. There is no long-term care. Adult day health does not exist. Adult day care is reducing in numbers as we speak.
Mhm.
So I know you've been focused in your meetings with care homes and that kind of stuff, but I'm saying that I think some attention needs to be put on the whole industry of adult day health and daycare, because at some point very soon, we'll disappear from the map.
Okay. Thank you for that feedback. I think, I think that's something we certainly can look at. I don't know to what extent we would have, the ability or influence to open more or to encourage that. I know certainly after the pandemic, a lot of adult day care and adult day health programs didn't reopen because I'm not sure in Hawaii. I'm speaking actually to my experience in New York State. So if it was similar here, I'm not sure. But um, people not returning to those places, perhaps out of fear of communicable disease and COVID. So a lot of those providers did in New York State even needed to shut down and never reopened. I'm not sure if that was the same in this state or not.
Paula, this is Caroline. I think it was very similar. I think as they reopened, they didn't have the capacity to keep the staffing levels that they
Right.
needed. And I think that's why we've seen those shutdowns that he's speaking about between 2023 and 2024.
Mhm.
I know Hawaii County only has one. I believe it's in the Hilo area, and it's just
Yep.
it can't service that huge
Island.
landmass over
Yeah,
there.
so
Yeah.
the 2 have closed on the Big Island, and
Mhm,
so now there's only 1 left.
mhm.
There's another one closed in Lahaina. So our islands are really, as far as I'm just saying, focusing on adult daycare and day health. This is the area that somehow we gotten forgotten. And I'm just saying, I love to meet with, I'm the president. I love to meet with somebody and talk about the issues and figure out how can we make it better. I don't know.
Harrison, could I reach out? This is Caroline Cuddyra. I'm the director for the Executive Office on Aging, and your number's on the screen here. Could we reach out to you for further conversations? Because this could be part of our long-term care planning that we're doing.
That would be great. And
Okay, I
the
got your
beginning.
number. I got your number.
Yep,
Harris,
yep.
also include your email address. That might be helpful as well for the follow
Yeah.
on the
And just
chat.
to give a little bit of context, so right now, the contract agency that OCA has for the inspections for the adult daycare, we have about 29, I think, and that's spread across, I believe, all islands.
All islands, correct.
Yeah.
Yes.
Right. And then adult day health, I'm sorry, I don't have a figure for you as to what that would be, but the
I
adult.
believe there's 4 left.
Okay, yeah.
So the model had great intentions, but it's
Mhm.
not working.
Yeah.
And so I'm just saying maybe it needs to be revisited, and
Maybe
otherwise
yeah,
this
for
whole segment is going.
another session, maybe, and maybe you could do a session offline with Paula and also with Caroline, because we do want to round out that whole continuum of care. And if adult day health and adult daycare are ways in which we can keep people at home and age in place with support services, I mean, I think that's even more cost effective than being in assisted living. So I think that is something that we should be focusing on. So thank you for bringing it to our attention.
Well, thank you, Sharon. And yeah, we talked before, so I'm just coming forward and saying I need help. My association needs help, and just asking. I need some wisdom. So anybody that's willing to talk with, I'm willing to talk.
Great. All right. Thank you. Thank you for bringing it to our attention.
Thank
We will talk offline, and if there's something
Yeah.
to go forward, we can share with the Kupuna.
Yes, I didn't want to take too much time. Like,
Thank you. Thank you very much.
Thank
thanks. All right.
Are there any other questions?
You know, I don't want to divert from the current topic, but I do want to readdress the issue of the unlicensed facilities. I did notice in the chat that Shelly Ogata had questioned, what about referrals to unlicensed facilities? So the topic of unlicensed facilities has a lot of, I should say, problems, period. But we need to address one thing at a time. And she's asking about the referrals specifically to the unlicensed facilities. Shelley, would you like to speak on that?
Shelley, are you muted? I don't think Shelley's here.
Okay, so I believe that she's talking about there's some doctors that refer specifically to unlicensed facilities. And that was one of the problems that we were wanting to attack in the last legislative session. And how are they going to be reprimanded? So can we talk about that?
Shelley says her mic isn't working, but I think that she is. She is talking about people referring folks to unlicensed homes. It's not just doctors. There also could be other homes referring them. They come from a variety of angles, if you will.
So
how do we deal with
Paula,
that?
are you folks looking at that of the not just the unlicensed, but the referrals to unlicensed, and that's one way of getting at eliminating the unlicensed?
So I think we would need to look at that more, Senator, and see, and part of it is how much we're really able to get on these unlicensed facilities, right? In terms of you know, what information we're able to glean, and that's if they even let us in the door. If they're not licensed, a doctor doesn't necessarily need to refer them because there is no requirement for that. They're not required as they are with a licensed facility to follow all of those rules. So I don't know how somebody is getting into an unlicensed. It could be with a physician. It could be because a family member has reached out and wants to get this person into that care home. I think we would need to look into that a little bit more and see what could be done if that is happening and hold those providers accountable to that.
So
I think
either Shelley or Rick or
well, it's actually it's happening, Paul. I'm sorry. There's actually been huge fines for unlicensed homes recently. So this is an issue we've been dealing with for some time. But go ahead, you guys.
Yeah, but it's the referral. It's knowing the unlicensed homes, and you get them, but it's the ones who aren't being caught, and the docs or whoever is referring them to the unlicensed.
Well, when I was at Right at Home, what was happening is it would be the actual homes. It'd be their friends that would refer to friends who were unlicensed because they didn't have the room for them. There were not enough beds out there, and it takes a while to get licensed. So those are, I remember all the way back when we had like a specific meeting just about that at the legislative level, where folks gave testimony, and the actual care homes were actually referring to their friends who were not licensed. And there's a couple of different angles that was happening. John and you guys, you may have even more information about this, but it's been going on for some time. I can tell you when I did do in-home care prior to COVID, we actually had people die in these homes because nobody was inspecting them. We would come out and visit, and we had a horrible case where a lady was actually duct taped to her bed, and she did die
Oh.
in our care. I mean, I'm sorry, but it was that. I mean, just like John's broccoli story, it was that extreme because nobody was monitoring these places, and
Okay.
yeah, it was really quite alarming. I'll stop.
Yeah,
Thanks.
thanks, Rick.
I had a question.
One more,
Have you,
because we're closing
okay,
in.
I'm sorry.
So-
Okay.
so,
Quick
we
one
can-
was, have you looked at the Airbnb model that the city and county went after Airbnbs because they were not licensed and they didn't pay taxes? Anyway, just a thought.
Well, you can talk with Paula and Caroline and maybe look at some of these issues of unlicensed. And now, if you have any specific information, or Shelley, also maybe form a little group with Paula and Caroline and see what we can do in terms of that really big puka in terms of quality care. Yeah,
People
but thank you.
can go to the public access
Yeah,
room. Act 148
okay,
is the law regarding unannounced, unlicensed homes.
and then what
It was
is
first signed into law back when Abercrombie was the
Act
governor.
148?
Act 148.
What year was
Yeah,
that?
so it was first Abercrombie. It was updated under EGA.
No, what was the
it-
year? The year when it was,
I think it was 2018.
okay, okay,
It was July 6, 2018.
okay, great. So thank you, everybody. Thank you, Paula. This was
Thank you.
innovating conversation here, and it so we'll be able to move forward and get more information, especially on getting quality care in our homes. So thank you so much, and thank you for what you're doing to really looking at OCA and shifting its kind of the way that you're moving forward, and maybe looking at the unannounced visits with John a little bit more.
Yes, thank you very much, everybody. I appreciate your time today. Thank you.
Thank you.
Thank you.
Thank you. And we have just a few more minutes, but I just want to announce that the legislature is opening on the 15th. We have a legislative timetable that Charles will put up on the screen. And if you look at the 15th opening day, 17th, the Kupuna Caucus bill package. So if you have bills or proposed ideas and you haven't sent it to Charles, please do as soon as possible. These have to be sent to our drafting agency, so they must be in. And the state address by the governor on 21st. I do want to tell you that you can send it to either Charles or Alex is my new legislative staff. So he will also be taking over a lot of the work on the bills. And you can track the bill status on capital.hawaii.gov. But please get any bills that you have other than the package that you would like introduced, submitted as soon as possible. And Corey and I can talk about the bills in terms of what we can help you with. But the Senate has unlimited, so we probably will do the most of the bills if Corey cannot. But we hope, Corey, I see a lot of representatives on the screen, so we may have other partners as well. Representative Temple. So you can see them all. Thank you all for joining us. This is wonderful to see so many representatives, and I see senators also. While we see Carl Rhodes, Brandon Elefante, and Linda Coit. So thank you all, and Happy New Year, and we'll see you next time. I think Jack Lewin, Dr. Lewin would like to present the long-term care plan at the next meeting in February. It'll be February 7th. And for Harrison, if you work with Caroline and Paula and others, maybe we will have a session following on adult care and adult health care, adult health and adult care.
Fair enough.
Okay.
Thank you for looking
Yeah,
forward.
thank you. Thank you for bringing it up. So any other announcements by anybody? Representative Chan, my co-chair, my trusty co-chair.
Nope, I think you covered everything.
Okay.
Just want to say Happy New Year, everybody.
Yeah, Happy New Year, everyone. We'll